Good afternoon. When Yair called me a few months ago and asked me to give these lectures, first of all I said thank you, and then I asked why do I get the most difficult problem. But I'll try, and I don't know if it pursued you, but I'll try to look on the other side and to say be aware of patients with indeterminate colitis. Now, we know that, as was said, about 10% of IBD patients don't have enough diagnostic criteria to make a definitive diagnosis of either ulcerative colitis or Crohn's disease, especially in the setting of fulminant colitis. These patients are diagnosed as having indeterminate colitis. Now, the diagnosis should really be based on clinical pathological criteria rather than only histology. And it is most important when the patient is going to have surgery, because if we treat him medically, then it doesn't really matter if he has indeterminate colitis or UC. But once he goes to surgery, it is more important. Now, proctocolectomy and IPA, as we all know, is the gold standard for patients with ulcerative colitis. Now, the critical question we have is whether to advise it to patients with indeterminate colitis. Now, the main fear is the possibility of developing Crohn's disease after the operation, and it's a point of anxiety not only to the patient but also to the surgeon. Now, the reports in the literature are inconclusive when we look into indeterminate colitis patients, and there are several major clinical concerns that we need to look, and that's complications, mainly perineal complications, the long-term functional outcome, the rates of pouch loss, the development of late-onset Crohn's disease, and the quality of life of patients. Now, the conflicting results arise mainly since we don't have a precise diagnosis of indeterminate colitis, as we heard before. Most of the studies are retrospective. The number of patients are usually small. The follow-up is not usually optimal. And, of course, we have a referral center bias. Now, the first point, which I think all would agree, is that indeterminate colitis patients are more likely to develop perineal complication than ulcerative colitis patients. And here you can see a small literature review that shows you that up to 44 or 50% of patients have a pouch-related fistula at some point. Now, here, a study that was published in the DCR in 2002 shows you that patients with indeterminate colitis have 26% late complications, mainly pouch-related fistulas, as opposed to only 10% in ulcerative colitis patients. So yes, they have more perineal complications. Now, the other important point is the pouch failure rate, which may be higher in indeterminate colitis patients, and I say maybe because we saw papers that showed that the pouch failure rate is not higher, but on the other hand, there are papers that show that pouch failure rate are indeed higher, and here you can see again a literature review, and you can see that in some of the works, patient had increased risk of Crohn's disease, developing Crohn's disease, which means higher pouch failure rate, which is about 50%, and only about 10% in ulcerative colitis. Now, here is a work done, published in 2000, took 1,500 patients, and you can see that the overall complication rates during 10 years of follow-up was again higher in patients with indeterminate colitis. Now, again, we talk about pouch-related fistulas, which the incidence was higher. We talk about pelvic sepsis, and again, we can see here that indeed the pouch failure rates were 23% in indeterminate colitis and only 9% in ulcerative colitis. And if we look at what happens after 10 years, we can see that if you have ulcerative colitis, your probability of retaining the pouch is 90%, while if you have indeterminate colitis, it goes down to 73%, and the difference was statistically significant. How many patients convert from ulcerative colitis to Crohn's? About 2%. How many patients would convert from indeterminate colitis to Crohn's disease? 15%. Again, a number that was in that study statistically significant. And if you look at the Kaplan-Meier curve of the probability of remaining free of Crohn's disease, you can see that it's almost 100% in UC, but less in indeterminate colitis. Again, another work, quite an old one, published in 1997. Again, you can see that the conversion from UC or indeterminate colitis to Crohn's disease is much higher in indeterminate colitis patients. Now, again, complications, you can see that in ulcerative colitis patients, perineal complications were only 23% as opposed to 44% in indeterminate colitis. Pouchitis was almost the same, but pouch failure was higher. It was 12% in indeterminate colitis and only 2% in ulcerative colitis. And their conclusion was that because of a higher rate of pouch failure, perineal complication, and discovery of underlying Crohn's disease, an ileoanal pouch should be performed with caution in patients that have indeterminate colitis until there are more accurate diagnostic differentiations. And my next few slides will try, if you have a debate, then how can we resolve the debate? And we need to improve. And how can we improve? And the first thing we need to do is to have a good diagnosis of indeterminate colitis. And as was said before, the diagnosis should be made only after colectomy and not on biopsies taken during colonoscopy. And if we think a patient is not UC or Crohn's disease, before surgery, then we should term it IBD unclassified and not indeterminate colitis. So that's the first step. Now, the second step is when you operate a patient with indeterminate colitis, open the colectomy specimen. And be aware, look for features that might predispose the specific patient to Crohn's disease. If you think that you have the features, then you can do two things. One is do an endileostomy and close this patient and wait for final diagnosis by the pathologist. And the second is do a frozen section and try to get a diagnosis. And again, the pathology is a very important unit, and you need to have a very expert IBD pathology. Another thing that is very important is to have subgroups of indeterminate colitis, those that favor UC, those that are true indeterminate colitis, and those that favor Crohn's disease. And we need really to identify those that resemble Crohn's disease in order not to pouch them, or I don't know if to say to pouch them with to be very cautious. And during the years, there are some reports that say, look at the distribution of the disease. If it's atypical, then probably the patient has Crohn's disease. And look at superficial fissuring ulceration. And again, if the pathologists do see them, then the patient is indeterminate colitis but favors Crohn's disease. And you can see here that in a work done in 2000, they tried to find which characteristics may distinguish a patient with indeterminate colitis from being UC and Crohn's disease, and none of them was statistically significant. The only one that almost reached statistical significance was the atypical distribution, which means skip lesions or rectal sparing. Another thing we can do preoperatively is to take serological immune markers. We know that P-ANCA is more common in ulcerative colitis patients, although it's not 100%. And we know that the other markers like ASCA, anti-OMPC, and anti-I2, which are antibodies against antigens which are on a membrane of bacteria like E. coli and Pseudomonas. So if we need to take those blood tests for those markers. And if a patient is positive for the markers for Crohn's disease, even if the P-ANCA is positive, then we should suspect that the patient has Crohn's disease. And again, try not to pouch him. So the debate still continues, and we need to, to be more precise when taking patients with indeterminate colitis to operation, and really to be very, very careful. Thank you.